Thank you so much for inviting me. This is very exciting. This is the first time that I'm actually doing a webinar here in BC. All of them were based in California and US in the past, since I resided there for many years. And then I returned back to Canada, home, and now I'm busy here with functional neurology practice and chiropractic. I'm going to introduce myself very quickly. I don't want to take too much time on myself, obviously. Uh, as Miriam mentioned, Ashkan Jalili is the correct way of saying it. Usually people call me Dr. Ash or Ash, short form, very simple. You can ask your questions as we go through the slides. If you have any questions about certain components of the slides, always ask, and I will keep an eye on those and make sure that I answer it to the best of my abilities. I am a chiropractor in the province of BC, as Miriam mentioned. I have been a chiropractor since 2002. I'm also an associate professor of clinical neurology with Carrick Institute of Neurology in US. I have done my 700 hours of postdoctorate in fellowship of functional neurology through American College of Functional Neurology, and I've also done 300 and plus hours. I can't even count how many hours because it's always ongoing, of American Board of Chiropractic Neurology. I've also done about more than 200 hours of American Board of Metabolic Medicine fellowship hours. And I will explain a little bit of, on that as to what that means in my view of how to treat certain conditions, specifically movement disorders such as Parkinson's and any other neurodegenerative disorders. Now, a little bit of a history about functional neurology is the term that was coined by a fellow chiropractor who's also Canadian, Dr. Frederick Carrick, who has also a PhD in education as well as multiple research background. And he is actually at Bedfordshire with Cambridge University and Harvard Massey, doing a lot of research on mental health, TBIs, and neurodegenerative studies research. He is my mentor. I've been studying with him for the past 13 years for my own personal reasons. He is also the former director of functional neurology for the Carrick Brain Centers in Dallas and Texas, Atlanta, Georgia. He's assembled the world's largest database of dynamic computerized posturography outcomes related to neurodegenerative disorders, traumatic brain injuries, and other diseases such as Parkinson's and Alzheimer's, actually, around the globe. And I will tell you what the importance of this data gathering is in what is actually pertains to Parkinson's and other dystonias or any other movement disorders. And that's one of the pictures, the gentleman on the right-hand side in the middle. He's been published in many medical journals. He is widely respected in the world of neurology, medical neurology, as well as mental health. He did term the coin functional neurologists in the 90s based on a research. And that's a picture of Dr. Carrick and myself. I just wanted to put a little picture with this voice. That's me. This is just about a few months ago back in Cape Canaveral in Florida when we were getting trained on some teaching aspects of functional neurology. So I will explain what chiropractic neurology is, and then we'll define what functional neurology is. Chiropractic neurology, first of all, you have to be a chiropractor, which requires you to be 3 years to 4 years of studies in a post, after your undergrads is done, once you get to chiropractic college. Once you get to chiropractic college, you finish that 3 or 4 years program, then you have to basically follow a 300 postdoctoral hours of coursework in clinical neuroscience or what is called functional neurology. So functional neurology in definition is actually application of clinical neuroscience methodologies. It's nothing new. These are novel treatments that have existed for many years. However, Dr. Carrick actually brought it into a one specialty to treat multiple disorders of neurological disorders per se. After the 300 hours of postdoctoral work, we must pass one of the rigorous exams that I have ever experienced in my life, to be honest with you. It's a written exam, and then it's a performance exam. It's usually about 2 days long, 8 hours in the first day, another 8 hours in the second day. Um, and not so many people pass the first time. I got to tell you, I didn't pass the written part the first time, and I'll be honest with you, it's just the fact that it caused the biggest headache that I have ever experienced in my life. I was very nervous taking this exam, as a matter of fact. Too many little tiny components associated with it. Second time I passed, and it was great, really high marks, but that doesn't define who we are, because exams are exams. Is the clinical experience that you get in the office is what determines what kind of physician you are. To be honest with you, I don't know if the summa cum laude and things of that sort really don't mean much anymore. Anyone who passes these exams through the fellowship program, they get board certified in US through American Chiropractic Neurology Board. Unfortunately, chiropractic neurology is not established yet as a fellowship in Canada, and we are working very hard to make that happen. I am starting it in BC right now, and hopefully starting November, we will be teaching the functional neurology courses here in conjunction with Fortius Health, and hopefully we can get this a little bit more widely used among clinicians in BC, and hopefully make it more Canada-wide. So we call these doctors, like myself, diplomates or fellows in American Chiropractic Neurology Board. We use the body and environment to assess the neuropathway weaknesses and dysfunctions. And that's one of the most important components of what we do. So every person, let's say what we're talking about, Parkinson's, environment has a very different stimulation to the body of a person with Parkinson's than a person with a different disorder. Your brain senses very differently and perceives very differently than a person with, let's say, stroke or a normal body without any illnesses. And so we have to find out exactly how neuropathways from the peripheral nerves to the spinal cord to the brain stem and then to the cortex of the brain, how do they respond to a novel stimulus? Let's say the light, the sound, the taste, and things of that sort. How does the body respond to it? And we start honing into the neuropathways and see which neuropathway is weaker or has a dysfunction. And we start working with those particular neuropathways to implement different functionalities to it or different applications to bring them up to a, I would say, more of a logical functionality. Something that the person can perform. If it's tremor, if we can improve the rate and the frequency and latency of the tremors, it would be fantastic. So how do we do that? Our examination and assessment usually takes about a good hour, if not two. And I tell you, sometimes extremely exhausting for the patient. And the examinations basically check the cortex, we check different pathways, and of course, this next slide is what I have for the students, but I want you to see exactly how we go step by step and try to find and pinpoint areas of that area where patients with Parkinson's are suffering. And I don't want you to memorize this chart, of course. I'm not gonna, definitely not. No, we're not gonna ask this question. Just to let you know that we have to make sure that we find out about the entire brain complex and its functionality. Now, somebody asked, are DACNBs physicians like MDs? It really depends what state, what province you're asking. Chiropractors are physicians, but they are not medical doctors. In most of the states in the US, chiropractors are primary care physicians, meaning that patients can go directly to the doctor, to the chiropractor, and seek care. In BC, my experience in the past year and a half that I have been here, obviously, I am not at all a acting medical doctor whatsoever. I have certain scope of practice that I have to perform routinely an examination to rule out things that are not part of my scope of practice and make a referral that are based on judgments and clinical experience. So yes, chiropractors are physicians, but are not medical doctors. We have no prescription rights, and I think that's one of the reasons why chiropractic has been always separate, is because they try to do things. We try to do things with conservative and natural way without medication. If there is a medication or different other mainstream care required, we definitely refer them to their GPs or different specialists. The other thing that we look at as functional neurologists, most of us, is the mechanism of the injuries, for instance. We look at the neural pathways, inflammatory responses, and why there is a degeneration going on. Let's say with Parkinson's, we look at the blood work. Most of us are trained in reading blood works and depict what deficiencies are associated with the disorder that we're trying to deal with. I'll do a little chiropractic and functional chiropractic neurology comparison. Chiropractors in Canada and US are primary care physicians trained in sports, spine injuries, and other musculoskeletal issues. So if you take a registered massage therapist, a physiotherapist, and an osteopath, and then you add diagnosis knowledge, it becomes a chiropractor. So chiropractors in general are a conglomeration of massage therapists, physiotherapists, osteopathic in one, to be honest with you. That's basically what it is. We study about 4 years. And out of that 4 years, about 6 months to a year, depending on what chiropractic college we're dealing with, is clinical training in a clinic, seeing patients under supervision, just like residency. But it's 6 months to a year full on with treatments. And then we have to pass a board. There's a national board, there's a state board, there's a provincial board that we have to pass. And then there's a jurisprudence test that we have to pass in order to get licensed to practice in the province in Canada or states in the US. Chiropractors also well known for our effective techniques in joint manipulation based on the nervous system behavior. So chiropractic addresses the nervous system through manipulation of joints. This has been around since Socrates 500 years ago brought it to light. It's not a new thing that belongs to chiropractors. Osteopaths in the 1800s had developed a technique also. Some chiropractors can or will do rehabilitation specialties or clinical nutrition specialties. Somebody like myself who's always itching for more knowledge and see what is going on with the system, I have a clinical rehabilitation specialty, I have the clinical nutrition specialty, and I don't think it's going to stop there because there's always something new that I would like to learn and add to my knowledge, and hopefully I can obviously help my patients. Chiropractors also employ natural and conservative methods of care, as I said, joint manipulations, electrical muscle stimulation, exercises, massage, and different type of soft tissue manipulations. Now take that and put it on the right-hand side where the functional neurology is located. And so we do all that doctor of chiropractic does, plus the specialty that has become part of the profession. We do subspecialties in vestibular rehabilitation. We do subspecialties within the neurological realms. In, let's say, traumatic brain injuries, we do subspecialties in childhood developmental disorders. We do subspecialties in movement disorder. That's one of the things that I have done with Dr. Carrick. We do another 3 to 4 years beyond the 4 years of chiropractic of didactic and clinical training. Then we have to become board certified, and then we get trained in diagnosis and management of neurological disorders. So we are much more comfortable to treat Parkinson's and dementias and TBIs and post-stroke patients in conjunction with their doctors, their patients, other specialties that they're seeing. It's never you coming to me alone by myself. It is always the best model is the multidisciplinary and multidisciplinary care and approach to it. And that's practically was my practice in California, was made of myself as a chiropractic neurologist, we had a medical neurologist and multiple other specialties that we were all trained in the same class of things that we were treating. And it was a marvelous multidisciplinary practice where we all picked each other brains and information, and we never had the ego of saying who's got the best care, because ultimately it is not about your physicians, it's about you finding the right way of living your life with a quality of life that you deserve through different methodologies that exist out there. Now, the medical neurologist versus functional neurologist. As I mentioned, functional neurologists are not medical doctors. They are a fellow postdoctorate after they become chiropractors, after they become naturopaths, after they become medical doctors, after they become optometrists. We have optometrists in our specialty. We have psychiatrists and psychologists in our specialty. We also have recently acupuncturists who are doing fellowship in functional neurology. So we are trained to diagnose and manage neurological disorders. The only difference is the methods of treatment. I see my medical neurologist, and for any issues, any symptoms, since he knows me, he knows that I'm not going to be taking too many medications if it's not a necessity. He always guides me through that. So he uses different treatments such as medications or eventually surgeries if it's something that medication is not able to treat. That's what the medical neurologist does. Functional neurologists, we look at the pathways that have gone weak or dysfunctional, and we start working with those pathways as we go along with rehabilitations, or what is called neurorehabilitations. We offer non-surgical and drug-free methods, and we utilize novel applications. And we'll talk a little bit about those novel applications in a second. This testing in Parkinson's, obviously, you know better than I do. No single way to make a positive diagnosis. There's no blood test, although they're still working. The research is very good in finding certain factors in the blood, different markers that can be detecting some precursor to Parkinsonians. There's a DAT scan that could show dopamine uptake deficiency, and then UPDRS testing that most people are familiar with, etc. What do we do as functional neurologists? In our examination, as I mentioned, it could take 1 to sometimes 2 hours of test. Because we really, personally myself, I want to point and find the little of the details associated with the dysfunction available. Yes, I see the patient for Parkinson's, but Parkinson's is only the diagnosis. What could go wrong in the brain of a patient with Parkinson's? Everyone is different. Everyone's response to a stimulus is very different. So we try to find those deficiencies and we start working with those. And we'll go over them right now. So we perform a comprehensive medical history. We perform a physical and neurological examination. Most often we have to do a special testing. We want to see what the structure versus function are. So if I have a shoulder pain, let's say, for instance, I want to see, okay, there is pain in the shoulder. Well, that's the structural issue. How about the function? Can I lift my arm with using my shoulder? If I'm not able to raise my arm up to grab a glass of water from the cabinet, then that's the functionality issue. So we'll check those dysfunctions. And then we'll look at the vital signs. We check all your functional assessment in terms of your heart rate, your blood pressure, and seated, standing, and lying down on both sides, because it is very different for everyone. We want to see how the right brain is working with the left side of the body and how the left brain is working with the right side of the body. So we always do things on both sides. We check your balance through different technologically advanced methodologies. We use vestibular functions, the inner ear apparatus, obviously, the eye movements. It's super, super, super important in our practice. I am not an optometrist. I am not an ophthalmologist. But a big part of our fellowship training is eye movement, the neurology of eye movement, which is the window to the brain for us. We can detect issues and dysfunctions through eye movement tracking or saccades or coordination of the eye with the head movements. Really, really, really important. We also check the cognitive assessment, physical examinations, and of course, as I mentioned, the United Parkinson's um, rating scales. We always use it. Common test that we use in our office to measure is vestibular assessment, as I mentioned, using video oculography. We check your walking and your gait. That's a huge analysis, and it's super important as to seeing how the patient is walking, what arm is swinging more than the other, how the patient is stooping forward, how that fascinating gait is coming after how many steps. If I give my patient a, let's say, cognitive task while they're walking, can it get improved? Can the walking get improved? Can the swing of the arm come back? These are little things that we record and we start working with. We check the posture. Posture stability is humongous in functional neurology and even musculoskeletal care. And so we utilize another methodology is a newer technology that we just brought in about 2 months ago, the first in BC. It's called right eye brain assessment. It's an infrared technology, it's a computerized infrared technology. The patient sits in front of this computer and the infrared detects the eye movement. So then the patient will be guided to perform certain eye movement in different directions while the infrared reads the movement pattern. And any time that there is an interference with that particular smoothness of the movement, we can extrapolate that information and use it as a clinical application for treatments. It's phenomenal, and the response is just marvelous. It's majestic what we can do now with the brain. The neurocognitive assessment, as I mentioned, is part of it. The reflexes. The last one of this, at the bottom of this page, it says spinal and joint alignment. This is where I put my chiropractic hat on, and I will tell you that despite of the refusal by some medical establishment in the past that chiropractors and chiropractic manipulative therapies are of no essence, are of no benefit to the patient, more research has come out through big medical colleges and universities around the globe showing the efficacy of a chiropractic spinal and joint manipulation in changing the brain pathways. Yes, not about pain, changing the brain pathways. It is already documented, thankfully, because of the presence of a lot of this technology out there called functional MRI that is being used widely in neurological and clinical applications, clinical neuroscientific applications, or SPECT scans of the brain. Those are things that we can see post spinal manipulation specifically to what you want to do with that patient. We can see the change in brain pathways. That is very powerful for me as a clinician to say that yes, I could actually change your blind spots with a chiropractic manipulation to this upper cervical joint. And that's already been established in research and is being done all the time nowadays. So that next slide here, goals of examination, is for me to find out and identify any orthopedic and musculoskeletal issues and peripheral nerve dysfunctions because of the fact that most of my patients with Parkinson's, they do suffer from certain neuropathies. They have rigidity in musculoskeletal system. They do have pain that they come with. So this is extremely important for me to identify where the system is breaking down and what kind of neurological system, which neurological system is dysfunctional independently or the entire system as a whole. And then objectively measure these functions and try to customize a treatment for patients. There are patients that I have to see maybe once a week for 6 weeks. There are some patients that I have to see 5 days in a row, 3 hours a day for the neurointensive program. It really depends on individual cases. So everybody is different. Now, this is a picture of the video oculography that we perform to investigate patients with dizziness and balance disorders associated with movement disorder or Parkinson's. There's this camera with there's this goggles with the camera inside that it reflects the image of your eye movement on a big TV that is in the room, so I can see the movement, and we can extrapolate that data from this. It gives us a nice graph as to what is the speed of the eye movement, what is um, what is the speed of the eye movement to the right, what is the speed of the eye movement to the left, up, down, so we can extrapolate some information. Let's see, I have a question here. The question is about the characteristics of neuroplasticity. Um, Absolutely, what we do is actually the essence of neuroplasticity. I'm glad that you asked this question because in the few slides ahead, we'll discuss this a little bit more in detail. So this image of the video oculography will give me enough data as to how to define the upcoming care for the patient to provide neuroplasticity with what we know to do. Obviously, there's other medical tests to measure functions are available, but unfortunately, as a chiropractor in BC, since there is not much of a freedom to refer patients for MRIs or PET scans or any other test, then I'm my hands are tight. I have to utilize a GP or really convince some of the GPs by showing them research that, hey, this patient that I'm treating, that is your patient, can we please refer to a SPECT scan and or functional MRI in Vancouver? And they asked me, okay, tell me why. What would change if you had the result out of a functional MRI? And I would have to say, A, B, C, this is what happens. And I have to submit some research to them. This is the reason I would like to have this, so I can really customize the patient's care as opposed to throw the darts in the dark and see if I hit the target. And I don't like to do that. So most of the time, the GPs, the general practitioners, the family doctors, when they look at the research and they put that together with a little bit of a knowledge that I have in functional neurology, they usually say, okay, I'm going to go ahead and I'm going to prescribe this thing for the patient. And we usually get it done, which is really nice. PET scans, EEGs, other neurophysiological testing are available to find out what else can be done for our patients. This is an image of a tractography, MRI tractography. This is the inside of your brain, the inside pathways of your brain. So these are all the pathways. Now, the only problem in BC is that most doctors and neurologists are still not as advanced as my counterparts in the States, simply because they are so overwhelmed here that I don't even think they get the time to really sit through ground rounds to see an image like this and see exactly what can be done. To me, this would be very important, but unfortunately, we still don't have this technology here. But this is an image of, beautiful image, majestic image of this brain showing these pathways, that some of them are dysfunctional, so we can pinpoint what functionality they have and what we can do from an environmental perspective to improve the livelihood of these tracts. And that's the beauty of functional neurology, frankly. This is a SPECT scan. I'm not going to spend too much time in it. We do have a SPECT scan here in Vancouver that is being used, and I've already referred 2 patients, and it has helped tremendously with my treatments. These tests are fantastic. They are technologically advanced and really cool to do. But they fail to test how the brain responds to the environmental stimuli. As I mentioned earlier, all these tests are so nice. It's great to have a diagnosis, but it doesn't show how the brain is responding to sound, to light. And when a loud sound suddenly appears, a lot of patients startle so quickly. What is that about? We try to pinpoint to those things through our examinations. Medication is absolutely a needed thing for a lot of the disorders we're dealing with these days. I am absolutely not against medications. As a matter of fact, I probably would be one of the few chiropractors in Canada that I would say, you know what? You need to go on medication before if I can touch you. Really. And so I do that. It's not a problem. I'm not against anything. Anything that helps the patients, I am there for it. I have used it myself before for my own issues. But unfortunately, it cannot restore function. It reduces the symptoms, and I don't mind that at all. Um, Traditional treatment, obviously you know it, levodopa, some other things, some other medications are there. Deep brain stimulation, in some patients it works, some patients it doesn't. We do know that there's an estimated 6,600 new cases per year of Parkinson's being diagnosed each year in Canada. An annual cost of medical services per PD patient is over $120,000 a year, simply because of the fact that there are falls associated with it, tremor suppression medications, patients with depression, sleep disturbances, bladder and sexual dysfunction. These are all cumulatively add to over $120,000 a year. So if there is anything that we can do from a clinical application of clinical neuroscience application or functional neurological applications that are far cheaper than anything else out there, then I will promote that simply because I can see the changes are immediate and a lot less expensive to the taxpayer, obviously. Now, most of you guys know already that the presentations that we see, patients with tremor, bradykinesia, rigidity of the muscles, constipation. It's usually shoulder pain, constipation, and lack of smell is the first three things that we see, not the tremor. So why not looking at the whole patient as a whole and extrapolate that information and try to see what the brain is doing and start firing the brain a little faster. And then that's what we do through functional neurology. So, and that's one of the reasons we spend about an hour to 2 hours in terms of obviously the examination to find out specific dysfunctions. And this is the risk factors, obviously. Now, toxins, I mentioned toxins is because there were a few research from University of Berkeley a few years ago that showed a phenomenal link between a pesticide that is being used in our agriculture very widely, malathion specifically, was causing tremors in rats and hyperactivity in the baby rats. So they showed a parallel behavior in ADHD in rats and a Parkinsonian tremors in the older rats. So once they took out the malathion from the liver of the injected liver, then usually the symptoms went away. And unfortunately, I think, if I'm not mistaken, Canada, we still use the malathion as a pesticide. It's still considered quote unquote safe for usage, but there's a lot of those studies are coming out as well too. We get overwhelmed with a lot of research these days. Then you already know about, so I'm going to skip through some of these tests, some of these slides, because posture, pull test, gait assessment, these are things that we do. Unfortunately, the videos are not playing, so not a problem. One of the tests that we do is called trails making test, that you can trace the numbers from 1 to 25. You kind of connect them, and we time it. Of course, we do trails B, so you go 1A, 2B, 3C, and we want to see exactly cognitively how quickly you respond and you connect the dots, and how much rigidity can that trigger, etc. And then that would be one of the really efficient tests to find out if there is any Parkinsonian issues associated with it. The therapies that we perform, that's very important. A lot of people are asking, what kind of therapies can you do? The therapies are fun, as a matter of fact. In my office, most therapies are fun. You will never get bored with it because these are fun stuff that we do. We utilize the brain pathways to perform arm movement, hand movement, leg movement, feet movement, or eye movement with the head movement utilizing certain technology. And we'll teach adaptive strategies for systems that we cannot repair. Obviously, we know we don't have a cure for Parkinson's and many other disorders, but what we can do is to improve the quality of and the functionality of the nervous system, so we can restore some functionality back to the system. So you have a better quality of life, lesser progression of the disorder, and of course, diet and nutritional strategies when we check the blood to see if there's what are the deficiencies in the system, so you don't go on a massive tirade of supplements just because the book on Parkinson says you should take vitamins A to Z, and then amino acids A to Z, and then you go home with a bag full of supplements that you may not even be digesting to begin with. So you're creating a very expensive urine, obviously, because you're just getting rid of it. So it doesn't work that way. Unfortunately, you should not be taking too many supplements, and you should be taking supplements and nutrients that only your body requires based on a individualized blood work. This is another video that it doesn't play. It was on plasticity for one of the questions. Plasticity is changing the brain pathways by multiple repetitions. And that's what we now know, that the brain does change. The brain can be remapped. The visual system can be entirely remapped so you can see different. We can create stability in your visual system, which gives you less anxiety associated with movement, less anxiety with light or sound. It's very profound, the changes that can happen. We utilize vestibular therapy for Parkinson's, and it's not a vestibular therapy that we will push your head right, left, up, down, or have you spin in a chair. We find out where in which vestibular system, what part of the vestibular system is deficient, and we put you in that particular exercise only to increase the activation of that particular area. So vestibular system rehabilitation, or VR, is effective at reducing the symptoms and signs of Parkinson's disease, for sure. It's already researched and established. VR can reduce incidence of falls because you'll have a better input from and perception from your environment, so less falls. Reduce the frequency of hypotension or the dizziness that you get from a seated to standing. And also spatial orientation, where you are with respect to your environment. The reduction of frequency and amplitude of the tremors. A lot of times we see that. And of course, reducing the rigidity associated with stiffness and pain associated with the Parkinson's when we perform the vestibular rehabilitation. Another really novel thing that we do is vagus nerve stimulation. This is getting pretty big. We've been using it for the past 7 years in the realms of functional neurology. Vagus nerve controls about 90% of your gastrointestinal system, your digestion, your absorption, and also it controls part of your heart rate inhibition. So if you have anxiety and your heart rate is high and you have this heart palpitation, guess what? We'll do a vagus nerve stimulation, which is really simple, 10-15 minutes, utilizing a TENS unit on the earlobe, specific areas of the ear that have been researched widely in big medical schools and, of course, the U.S. Army for their veterans that are coming back with PTSD and TBIs, or traumatic brain injuries. They have been using this for many years now. And so we utilize that in our office. We do what is called PONS, or neuromodulation, through stimulation of the tongue, which reduces or increases the vagus nerve stimulation and reduces the autonomic or fight or flight response associated with anxiety of a Parkinson's patient. So many things can be done from our perspective, which are novel and are phenomenal, and the outcomes are just fun to see when the patient changes immediately in front of your eyes. And this is my, I guess, the reward in my office is that I am always smiling because I see the changes in my patients. This slide shows some of the eye exercises in the left upper corner. You see that there's a checkers. It's a video, but it doesn't play, but there is a dot that goes up while another one, the checkers, is stimulating another part of the brain. So we try to synchronize or increase the synapses in the brain by creating that plasticity that I was telling you. The more we do it, the more plasticized the system becomes. The picture on the right-hand side, the gentleman standing in front of this big TV, is a touch TV that the stimulus comes out and the patient has to touch and increase the dual tasking while keeping themselves in the balance zone and the green zone all the time. So we're doing double tasking, triple tasking, etc. And the next slide is another one that we utilize different apps to applications on your iPhone applications to increase different specific tones that are associated with the vestibular system, which causes that improves the balance of the patients in performing balance workouts, and Pilates utilizing eye movement, laser eye movement. Um, um, there's a question that says, do you have similar approach to dementia diagnosis and treatment? Absolutely. As a matter of fact, the the entire realm of this functional neurology is to find neuropathways that are weak. Again, whether you have a headache, Parkinson's, dementia, TBI, post-stroke, we have to find ultimately the weakness in the neuropathways or dysfunctional neuropathways and start pushing them so they don't really break beyond their ability to metabolize. We keep them always at the level where the brain says, okay, this is good enough. And that's how we check the pulse all the time, making sure that your pulse never goes above the normal. And so you never create reversal of autonomic nervous system. So that's the kind of stuff that we do. So in summary, our therapies for specifically Parkinson's is directed towards cerebellum for balance, vestibular system for eye and head synchronization and balance, spinal, usually with adjustments specific to the areas of need, and eye movements. Specific areas can be triangulated through examination and testing, as I mentioned. Functional chiropractic neurology approach could offer a multimodality approach to improve the quality of life of a Parkinson's disease patient, and we do it every single day in our practice. We do employ a physiotherapist who has a PhD in physiotherapy and is very well versed in vestibular system therapy, and she works with me. We have a massage therapist in practice. I have a naturopathic doctor in our office who is extremely well versed in neurological disorders, and so if we do need anything from him, we'll always request. I do work with neurologists in North Vancouver and multiple physiatrists or sports medicine doctors if we need any kind of treatments that are required beyond my scope of practice. So having said that, we culminate this. I think I went over a little bit and I tried to do it as fast as I can. I apologize if I spoke not so clear and too quickly. We are located in West Vancouver, BC, in Caulfield Village, a small place, simply because I moved back to Canada about 2 years ago, and I thought, all right, I really want to just treat the brain. I have been in practice for 15 years, 16 years now, working as a functional neurologist for the past 13 years, and my passion is the brain. Anything that comes out, I am there for the brain. So we are bringing different other novel treatments added to our office in the next 3 to 4 months. One of them being a gyro stem. It's a big equipment where the patient sits inside. Was designed by NASA, and it has a phenomenal ramifications for neurological rewiring.